I grew up in Craig.
Oh, did you?
But I wasn't the one that was on the Associated Press.
Good afternoon, everyone. We're going to call this meeting of Health and Human Services to order. We only have one agency readout today. That is going to be the Department of Human Services, Social Services, and our budget analyst is Mr. Samuel Quist. And I'll give the mic to Mr. Quist.
Thank you, Senator McCray. The Social Services Administration budget in FY25 increases by 12 million overall, or 1.7% from the fiscal 2024 to a total of 731.7 million. In the performance analysis section, which begins on page 4, I wanted to briefly highlight 3 areas where the analysis is asking the department to comment. The first, in relation to Exhibit 1 on page 5, DHS is asked to comment on efforts it is taking to reduce the recurrence of maltreatment and the rate of victimization of youth in foster care. And in Exhibit 2 on page 6, which shows the rate of placement moves for children in foster care, DHS is asked to comment on the fact that this rate has increased from fiscal 21 to 23 from about 5.19 to 7.98 per 1,000 days of foster care. Exhibit 3 on page 7 is showing the percentage of children exiting to permanency within 12 months of entry. DHS is asked to comment on the relative decline over the past 5 years in this area and efforts to improve that. The proposed budget discussion on page 9 begins. I'd like to first highlight there is a proposed fiscal 2024 deficiency of appropriation of 28.4 million in general funds for the foster care maintenance payments program. This deficiency supports increased placement costs above what was originally estimated in the fiscal 2024 budget. On page 10 is the overview of agency spending for fiscal 2025. You can see the foster care maintenance payments program totals about 350.1 million. The other large category is personnel costs, which total about 284.2 million. I would note there's a slight labeling error on the chart. This is labeled as other, but it should read as personnel expenses. And within personnel, the largest area is child welfare services. Under the proposed budget changes on page 11 and 12, within the $12 million overall increase, about 6.1 million of the increase is in the foster care program, where 5.9 million is in the remainder of the agency expenses. Outside of foster care, the largest increase, personnel increases grow by about 13 million. And then towards the bottom of the chart on page 12, there's about a $7.9 million decrease for the Montgomery County Block Grant, the portion for child welfare and adult services budgeted under SSA. If you recall, during the hearing for the DHS overview, the department indicated that there was a budgeting error in fiscal 2024, which caused spending to inadvertently increase. And in FY25, the funding is reduced to be in line with prior year levels. Within the foster care program, the largest increases are 28.3 million, which is budgeted for implementation of foster care provider rate reform, as well as an additional $12 million, which is funded for provider rate increases. These are largely offset by decreases which total almost $40 million in other areas of program spending, which takes into account both the fiscal 2024 deficiency appropriation as well as decreases totaling about 13.7 million from other unallocated program reductions. By fund type, federal funds for foster care increased by about $20.2 million, which allows general funds to decrease by about $14.2 million. This is largely due to the increased allocation of federal temporary assistance for needy families funding going towards foster care. On page 13, there's a little more discussion about the implementation of the new foster care provider rate structure. DHS and proposed regulations has outlined the framework for new foster care provider structure. The proposed regulations would have an effective date of July 1st, 2024, corresponding to the beginning of fiscal 2025. DHS has outlined that the structure would mainly focus on providing rates by class of service rather than individual providers, as has been done in the past. As mentioned in the previous exhibit, there's $28.3 million in the budget for this purpose, as well as $12 million for provider rate increases. In the bold language on page 14, DLS is noting that it's unclear why there are two separate funding sources for those two separate categories, as well as asking the department to comment specifically on how those funds are going to be used in FY 2025, as well as a timeline for usage for the different components of implementing the provider rate structure. The next section of the analysis goes into the DLS forecast for the foster care maintenance program. Exhibits 7 and 8 provide the actual caseload data. Exhibit 7 for the foster care caseloads, which have been generally declining over the past 5 years, impacted by both the pandemic as well as the department's overall efforts to reduce the number of children going into care. In fiscal 2023, the total decrease in foster care was about 1.4% overall. However, within the individual placement categories, the purchased institution placement categories actually grew by about 2.8%. In Exhibit 8 for subsidized adoptions and guardianship caseloads, subsidized adoptions decreased by about 4.2% in FY 23, while subsidized guardianships increased by about 2.3%. Exhibit 9 on page 17 is showing the DLS caseload estimates in FY 2024 and 2025. Based on the current caseload trends, DLS is estimating that in both 2024 and 2025, caseloads will continue to decrease from 2023 levels by about 1.4% overall in FY 24 and about 0.5% in FY 2025. However, although an overall decrease is forecast based on current caseload trends, we are continuing to estimate that within the categories of purchased institutions and subsidized guardianship placements, there will be slight increases in these categories. Exhibit 10 on page 18 shows data on the placement costs for the 3 most expensive provider foster care placements. Overall, all placement costs grew by about 17% during FY 23 and have grown by an additional 8.1% in FY 24. This placement growth is part of the reason why a deficiency appropriation was brought in FY 2024 to provide additional funding. Specifically among the purchased institution placement costs, which is the most expensive placement type, these costs grew by about 24.3% in FY 23, which is reflected on the chart. You can see the large increase in that category. Exhibit 11 on page 19 presents the DLS forecast for expenditures and revenues for the program. In fiscal 2024, DLS is forecasting a surplus of about $15.3 million. And in fiscal 2025, a surplus of about $5.6 million. Due to the estimated surplus in FY 2024, DLS is recommending that the proposed deficiency appropriation could be reduced by about $7 million, which DLS projects would still leave adequate funding to support any increases in program costs that may occur through the remainder of the fiscal year. In fiscal 2025, DLS estimates that program funding levels will be slightly more than adequate and there will be a modest surplus. If the entirety of the $28.3 million budgeted for rate reform and the $12 million budgeted for rate increases are ultimately used for that purpose to fund placement costs. However, in its forecast, DLS noted that the fiscal 2025 allowance does not provide sufficient funding to provide additional rate increases above fiscal 2024 placement cost levels, despite there being funding included in the budget for this purpose. Due to other reductions in program funding in other areas for placement costs, this would effectively result in the funds budgeted for this purpose to be used to maintain funding for placement costs at fiscal 2024 levels, resulting in a deficit to develop if substantial rate increases were provided in FY 2025. On page 20, the personnel data summary, I'd point out that the current vacancy rate as of December 31st was about 12.9%. which does represent a decrease of about 96 vacancies from the prior year. The largest amount of vacancies were in the Child Welfare Services program. The first issue beginning on page 21 presents additional data on the out-of-home placements by youth in care. The main points I would highlight in this section, first, Exhibit 14 on page 23 for out-of-state placements. You can see the number of out-of-state placements has been generally declining since 2020 and was about 278 children in FY 2023. There's some similar data. This is roughly similar to the caseload data presented in the previous section. Exhibit 15 and 16, you can see the foster care caseloads are continuing to decline, and the rate of entry into care has declined over the past 5 years. Exhibit 17 on page 26, the analysis does ask DHS to comment on the increase in the rates of re-entry into foster care for children reunifying with their family of origin. This increased by about 1.2% in FY 2023. However, the rate of reentry for children exiting to guardianship has continued to decline over this time period. The final three exhibits in this section go into in-home family preservation services. I would just highlight on page 28, these two exhibits are showing the percentage of children involved in in-home family preservation cases who had indicated Child Protective Services findings or required an out-of-home placement, either during services or within the 1 year after services. You can see that although the percentages have fluctuated over time, the percentages are relatively low overall, indicating the degree of effectiveness of these services in preventing child maltreatment. Turning to the second issue in the analysis, the first section discusses more about evidence-based prevention practices implemented under the Family First Prevention Services Act. DHS has been asked to provide a report to the budget committees on this issue in recent years. The most recent report indicated that of the 4 main evidence-based prevention practices being implemented, there were about 319 families total served in about 18 jurisdictions. On page 30, there is bold language asking DHS to comment on the status of approval of the revised public assistance cost allocation plan and the current availability of DHS to seek federal reimbursement for the evidence-based prevention services that are currently being implemented by jurisdictions. Additional discussion in this section goes on to discuss some of the evaluation of the outcomes for these prevention practices. DHS indicated in its report that for families who completed participation, there was a lower percentage overall in the number of children who are requiring a subsequent out-of-home placement compared to families who did not participate in these programs. And the other area I would highlight in this section on pages 32 and 33, there are additional discussions of the Qualified Residential Treatment Program designation process. The FFPSA, in addition to providing provisions related to evidence-based prevention practices, it also included provisions amending the eligibility of states to receive federal reimbursement for certain non-family based placements in certain settings over the duration of 2 weeks under certain circumstances, unless the provider has been designated as a QRTP or a Qualified Residential Treatment Program. In fiscal 2022, the first 6 providers had received this designation. In fiscal 2023, DHS worked with the Department of Juvenile Services to facilitate a second round of applications for designation for QRTP status. However, there were ultimately no additional QRTP providers designated during the fiscal year. And at the end of fiscal 2023, the number remained at 6. At the bottom of page 33 of the analysis, DLS notes that although the FFPSA does not specifically prevent non-family based placements over 2 weeks in duration, the FFPSA limits the availability to seek federal fund reimbursement for these placements after 2 weeks. Therefore, a lack of designated QRTP providers in the state limits the extent to which federal fund reimbursement can be sought for these placements. And in bold language, the analysis asked DHS to comment on the future efforts to seek additional QRTP provider designations, as well as also asking DHS to comment on the current status of the state's ability to claim federal reimbursement for the funding of these placements. The final item covered in the issues section of the analysis on page 34 is noting that in recent years, the Joint Chairman's report has included committee narrative asking DHS to provide a report on child welfare staffing, as well as caseload to staffing ratios to meet the Child Welfare League of America standards. The most recent report on this issue was due on December 1st, 2023. However, it was not submitted until February 6th. And unfortunately, DLS was not given enough time to sufficiently analyze the data to include it in the analysis. Although the report is currently available on the website, if there are specific questions on this report, we can follow up after the hearing. I'd like to conclude by summarizing the DLS operating budget recommended actions, which begin on page 35 of the report. The first recommendation is to restrict funding pending a report from the Office of Legislative Audits indicating that all repeat audit findings from the June 2021 audit report have been corrected. This wasn't mentioned in the analysis, but there was a letter submitted by OLA to the budget committees on May 15th of 2023 indicating that there were some of the audit findings found in that report that were still pending. And as a result, the Joint Audit and Evaluation Committee has requested that there be a language inserted in the budget bill requesting a status update on that. The second recommended action is to restrict funding pending the receipt of the next year's Child Welfare League of America caseload staffing to caseload ratios report, as mentioned previously in issue 3. The third recommended action is to restrict funding appropriated for the provider rate reform and provider rate increases until DHS submits a report specifically outlining more details on how that funding is intended to be used in fiscal 2025 and providing an updated timeline. Issue number 4 on page 38 is recommending committee narrative requesting a report on out-of-home placement hospital stays and specifically focusing on the hospital overstay issue. This was also covered in the DHS overview hearing a couple of weeks ago. Recommendation number 5 is requesting a report similar as in prior years, discussing the Family First Prevention Services Act, focusing on evidence-based prevention practices, how the outcomes of those practices are evaluating, and then also discussing the Qualified Residential Treatment Program designation process I mentioned previously. Recommendations 6 and 7 are annual budget bill language, which restricts funding in the foster care maintenance payments program and the child welfare services program to those purposes. This would prevent any kind of transfer to other purposes, which would result in a deficit in those two programs. And the final recommendation is to reduce the fiscal 2024 proposed deficiency appropriation by $7 million, as discussed previously, related to the forecast. That concludes the presentation, and I can take any questions. Thank you.
Thank you, Mr. Quist. Seeing no questions at the moment, I'd like to bring up the agency, Secretary Lopez and his team.
Good afternoon, everyone. Chairman Cray and members of the subcommittee, I'm Rafael Lopez, and I serve as the Secretary of the Department of Human Services. We thank the Governor and the General Assembly and all the staff for their support. Joining me at the table today is to my right, Principal Deputy Secretary Carnita White, and to my left, Acting Chief Financial Officer Kirill Resnick. And behind us is a squad of senior leaders to answer any questions that you might have. We'd like to take this time to highlight 8 key areas of our budget that are fundamental to us launching a new era of child welfare in the state of Maryland. They are implementing the Federal Family First Prevention Services Act in Maryland. 2, ending the practice of youth aging out of care in Maryland. 3, creating a kin first culture in the state. 4, reforming how Maryland compensates care providers. 5, addressing hospital overstay status. 6, addressing hotel stays. 7, course correcting MD Think, and 8, rebuilding state government. Given the fact that we've been before you on a couple of occasions, we won't repeat those same pieces of testimony so that we are thoughtful about your time. On the first issue of implementing the Family First Prevention Services Act, we want to ultimately prevent children from coming into foster care in Maryland in the first place, and doing all that we can to make sure children and youth stay safely together with their loved ones. We also want to reduce unnecessary removals from families, and we need federal funding to do so effectively based on science, data, and common sense. And what's important to note is that over the course of the last couple of years, Maryland has struggled with doing those things well. And so we want to make sure we actually are taking advantage of every single federal dollar opportunity to invest deeply, not just in the children and families we serve, but also in our structure to make sure we are meeting the ultimate goals of Family First, which is about preventing unnecessary foster care placements by proactively addressing the top 3 reasons children enter foster care in the first place, both nationally and in Maryland. And among these are substance use disorders, mental health issues, and the challenges of parenting, all while drawing down federal funds to keep children safely with their families. Of note, for the record, Maryland has not drawn down a single dollar in federal funds for prevention. That's $0 since the Family First Prevention Services Act was passed. And we estimate that nearly $10 million in federal Title IV funding to prevent foster care was simply left on the table over the last 5 years. And to draw down more federal funds for which Marylanders are eligible, we will also improve how we identify children who are eligible for federal Title IV funds when out-of-home placements are in fact necessary. For example, DHS could increase its Title IV foster care administrative revenue by $1 million a quarter or $4 million per year. And doing this is just the beginning of trying to make sure that we're doing all that we can as a department to serve Maryland's children, youth, and families. It's just the first step we can do to responsibly invest Maryland taxpayer dollars, draw down those federal funds, and be clear that it's not just about the money, as our colleague senator has pointed out, and she's so right. It's actually about the moral, ethical imperative to do right by kids and families, in addition to using every dollar to do just that. The second area we'd like to highlight for you is the issue of ending the practice of youth aging out in Maryland. Despite reduced entries over the last couple of years in foster care, unfortunately, 64% of youth entering care at age 14 or older aged out of Maryland foster care as of FY 2021. And if we think about Maryland in the context of the nation, we actually age out nearly twice as many older youth in the state of Maryland as compared to national data. And in Maryland specifically, when kids enter foster care as teens, they are 40% less likely to reunify with their family as compared to national data. How that plays out very specifically around the kids and the young people is that we need to make sure that we're doing all that we can to support 18, 19, 20, 21-year-olds to be connected to family by blood or by choice, because family matters. And specifically, to paint a very accurate picture of what's happening, non-Hispanic African-American girls are disproportionately aging out of foster care in Maryland because African-American teen girls enter foster care at higher rates and are less frequently reunified with their families. We will do better, and we're already accelerating our work to implement Family First, for example, to make sure we reduce the number of teen Black girls who come into care in the first place. Speaking of kin culture, I want to make sure and lift up my colleague and partner in this work, our Principal Deputy Secretary, and she's one of the first people I called when we were building our team. And I would like her to lift up the next 2 sections of the items we'd like to highlight.
So good afternoon, Chair and committee members. It's a pleasure to be before you again. When Secretary Lopez called me to invite me to join the Moore Mill administration, it was by no means an automatic yes. I was approaching my 30th year, which I celebrated last July, of service to DHS and to the state of Maryland and its people. But I always remain passionate about Maryland's most valuable asset, and that's our children and our families. And as many of you know, I spent nearly 8 years working at the Social Services Administration, and many of those as the executive director. When I left the position in 2014, we had just received the federal waiver, and we were set up to build a continuum of care to reduce the number of children in care. What compelled me to come back was what I watched and saw over the 8 years from a distance, but also what I imagined that we could be. And I wanted to spend my last years as a public servant rebuilding the very department that I have dedicated my professional life to. And so, in fact, one of the key items that we're urgently moving on is the importance of building kinship care for a kin-first culture in Maryland. We all know that when children can't safely remain at home, that they remaining with their kin, both biological or chosen, is in their best interest. We know that by research, we know that by common sense, and a matter of personal privilege, I know that personally. I'm a kin mother. My 26-year-old came to live with me when she was 4. She's my cousin by blood. And now I'm a grandmother, and I have lots of pictures on my phone to show you if you don't believe me. But not only was I a kin parent, my grandparents were kin parents. And I'm sure you can think about persons in your family who were kin parents, and you know personally how living with kin helps to strengthen your family, helps to keep you bonded and connected to your family and to your community. So I live and breathe this work. And by creating a kin-first culture, we seek to improve the outcomes of the very children and families we serve, to reduce family separation, which I would say is one of the most important things. Currently, about 23% of the children in our foster care system are placed with kin. We could do a lot better, and we are going to do a lot better. In fact, one of the strategic ways that we are proactively addressing the disproportionality, which you heard the Secretary talk about, which is often with Black girls, is by investing in kin care. We're working with the chairs of the Judicial Committee this session to bring our kin-first proposals to the table, given welcome changes in federal rules to better support kins. This year, Maryland will pilot a new kin-specific licensing practice in Baltimore City to refine and inform our statewide practice. Next, I'd just like to talk a little bit about reforming how Maryland compensates our care providers. And this is something else that started under my tenure when I was at the department over almost 10 years ago. Maryland has failed to reform its placement providers' rate structure to align with actual costs of care, provide flexibility for specialized services, and capitalize on federal funding. We are working to transform the structure to better meet the needs of Maryland's children and families by raising the bar of excellence. We estimate a loss of nearly $10 million in federal 4E funding over 5 years because Maryland has not kept up with the standards of national funding. We're changing this right as we speak. And Maryland has steadily and dramatically reduced the number of children in out-of-home care while protecting children's safety. For example, in 2007, we had over 10,000 children in foster care. Today, 3,804. While we're proud of that success, we will build a system that adapts to change. For example, often children that do require to come in out-of-home care are coming to us with complex behavioral and developmental needs. As group-based placements decline nationwide, we must be ever more vigilant to ensure children receive appropriate treatment services in Maryland. We have moved urgently to identify regulatory, budget needs to initiate the rate reform. We submitted regulatory changes and state budget submission. We will deliver a class-based rate structure to improve providers' ability to serve families while meeting critical gaps in the Maryland's continuum of care and allowing us to draw down more federal 4E dollars as well as Medicaid dollars. But more importantly, and I think this is what we all care for as public servants, the children and families will experience a more appropriate, higher quality, and tailored service with shorter lengths of stay. We'll be able to draw down $10.5 million in federal funding for direct care costs, as well as $7.6 million in Medicaid reimbursement for clinical services. We're happy that the governor's budget proposes $28 million investment in rate reform. This is an historic investment for DHS, for our providers, and for the children and families we serve. And with that, I'll turn it back over to Secretary Lopez to address the last few issues.
Thank you, Madam Deputy Secretary. As we continue to work with all of you in rebuilding trust and establishing strong relationships, we have been very transparent about some of the challenges that we found in the department of our first year in office. And one of those is the issue of addressing hospital overstays. I'd like to make sure and lift up. And so as the Principal Deputy Secretary said, we are working to modernize a variety of key components. And one of them has been the issue of a mismatch between what children need and the available residential treatment centers, or RTC beds, in Maryland for youth who require more tailored solutions to complex needs. Unfortunately, some of our young people remain in restrictive hospital or treatment settings for beyond when they are medically cleared to stay. And for the record, a hospital overstay occurs when a child in DHS care in custody remains in a hospital or other acute care facility 48 hours after a medical discharge. So as of today, there are 22 youth across the state in overstay status awaiting appropriate placement, which equates to 0.5% of all 3,804 youth in care as of today. To be clear, that 0.5% is still unacceptable, and we will continue to do everything in our power to generate new solutions. From October 2022 through September 2023, the number of children in foster care accessing inpatient psychiatric services increased by 22% over the same period in previous years. And that increase reflects the complexity of youth needs when they must come into care, because in-home services or family-based care was not appropriate for the child at that time. In the same period, prioritizing our work with hospitals and providers to reduce overstays led to a 23% decrease in the length of youth overstay within inpatient psychiatric care. And we're doing a variety of things to make sure we continue to bring the numbers down and to generate newer solutions to some of these old problems, including participating in weekly interagency conversations with our colleagues at the Department of Health, Behavioral Health Administration's Developmental Disabilities Administration, and the Department of Juvenile Services. We want to make sure we're identifying proactive strategies and monitoring the cases every single week to do all that we can to continue to reduce that number. Similarly, monitoring and tracking the data on hospital overstays and checking on placement efforts, both for in-state as well as out-of-state contracts. While we'll never prioritize out-of-state placements, that is still a viable option that we have to consider. And bringing that practice down will take us a couple of years as well as we expand our rate provider network that the Principal Deputy Secretary spoke of. Early in 2023, we dedicated a youth hospital liaison position to work as a mediator between hospitals, local departments, and the providers, especially around coordinating DDA eligible transition aged youth. And while none of this is perfect, or the entire set of strategies we are working on, we want you to know that we simply can't move fast enough to course correct this work over the last couple of years. We also want to lift up the issue of addressing hotel stay trends in the state. Similar to the issue of hospital overstays, this has become a typical practice in Maryland that we want to completely turn around. Here in Maryland, as of February 14th of this week, there are 54 youth in hotels rather than in a foster care placement for an average length of stay there of 62 days. I'd like to be clear on the record that hotels are not foster care placements, and anyone who assumes that living in a hotel should be the way we do things is mistaken, because who wants a child to be in a hotel? It's important that on average, we recognize that 19 youth began living in a hotel in each month of 2023. Again, that's 19 too many young people. We want to make sure that we are using accurate data to dispel the myth that there are thousands of kids or hundreds of kids across the state living in hotels. It's just simply not true. The average length of stay for all youth who were in a hotel during calendar year 2023 was 61 days. Again, too many, too long, but we're course correcting proactively. Similarly, our SSA team is working closely with the Department of Social Services across all 24 jurisdictions to make sure we are preparing and reviewing referral information, personally calling at all levels of providers, making sure we're reminding them of our contractual obligations to take in our youth when beds are available, and better understanding why sometimes our providers aren't always necessarily accepting our children, and working to resolve that proactively. In addition, we continue our efforts to expand the provider network. We've set the stage for trying to do away with the stalled conversations on rate reform, which we think when fully implemented will actually allow us to have more placements that better serve the needs of Maryland children. And thinking about data and tying that, we also want to lift up the importance of course correcting MD Think and CJAMs in particular. though you've heard us speak a little bit about that already, CJAMS is the acronym for the Child, Juvenile, and Adult Management System. It is the official system of record in the state of Maryland, where we manage the cases of all of our young people in care. We made significant key leadership changes, brought in a new executive director, rebuilt the leadership team, are increasing accountability for spend, for development of the application, and suspended all other development of new applications to make sure we're focused on DHS's 3 primary applications, which is CJAMS, specifically for child welfare and adult services, E&E, which is enrollment eligibility for benefits, and a CSMS, which is a child support management system for the child support system. To be clear, getting the tech right is only one piece of the problem. Making sure the tech responds to the needs for kids in care is our most urgent priority. Similarly, rebuilding state government. We can't do any of these reforms we've talked about, can't do any of the tech fixes, can't do any of these larger innovative efforts if we don't rebuild our team in state government. Specifically, we've done just that to the governor's challenge. And in this last year alone, in less than 12 months, we reduced our entire department vacancy from 15.2% on January 1 of last year to 9.69% on December 31st of last year. That's a 5.5% reduction, which equates to 338 filled positions. We mirrored that kind of urgency in the Social Service Administration, and we're pleased to share that in the same calendar year, we had a net gain of 88 new child welfare and adult service caseworkers and supervisors, reducing our program vacancy rate by over 5%. Similar to the department trend, we can't do enough to fill more of those roles fast enough, but we have moved very swiftly in this last year to do just that. To conclude, the Social Services Administration budget proposal was assembled in partnership with many of you. We're ready to deliver on bold investments, and we believe that doing so responsibly will help us make this Maryland's decade. With that said, I'll turn it over to our Acting Chief Financial Officer, Kuro Resnick, to briefly summarize our responses to the DLS analysis.
Thank you, Mr. Secretary. Thank you, members of the subcommittee. I'm going to respond to the questions and recommendations proposed by the analyst. I will summarize, but there's a lot more detail in our response. So obviously, I encourage you to look closer and read our full response. For question number 1, asking us to comment on the effort to reduce the recurrence of maltreatment at the rate of victimization. DHS has continuously remained above the national standard of 90.5% for avoiding recurrence of maltreatment. For FY23, that number for Maryland was 93%. We're working with local departments of social services and community partners to implement the Federal Family First Prevention Services Act to develop community-based services that support caregivers in the areas of substance use disorder, mental health, and the challenges of parenting, which address some of the top reasons why children enter foster care. Question number 2, asking us to comment on the reasons for the large increase in the rate of placement moves over the past 2 fiscal years. There are a number of limitations in our ability to quantify placement moves due to constraints built into the original design of MD Think and the preliminary application of CJAMS, which the Secretary described. To address the constraints, we're developing a metric to track the placement changes within specific time frames. The metrics will categorize placements based on the level of restriction. However, we do want to note that many youth who enter out-of-home placement come to us with behavioral health and developmental needs, which require a short-term, high-level placement initially, and then step down to placements with a lower level of restriction. Another example of why a placement change will occur is when a child moves from foster care to kinship care. Again, an initial placement is changed, but the change is necessary to serve the child's best interest. Question 3, asking us to comment on the reasons for the continuing decline in the percentage of children exiting foster care to permanency within 12 months. 64% of youth 14 and older aged out of Maryland's foster care system in FY21, which is nearly twice as many older youth compared to national data. We are engaging youth, staff, and community partners to pursue our goal with no youth age out of care, with no goal of that no youth age out of care in Maryland. First, we are implementing the Family First Foster Care Prevention Services to reduce the number of older youth requiring foster care in the first place. We are developing a Kin First culture, as the Principal Deputy Secretary described, to ensure that the children and youth have permanent family connections and reduce the length of time children are in foster care. We're actively building our family finding strategies and support kinship caregivers. To question number 4, asking us to discuss the status of legislative grant priorities and agreements. In September 2023, SSA issued $150,000 in general funds to the Baltimore County Department of Social Services for respite care services. and issued a grant to Concern Professional Services for Children, Youth, and Families in October of 2023. The grant was used to support children in foster care, recruit additional families, and retain current families. Regarding the status of the $500,000 as part of that grant, legislative grant priority, that was a contract that was executed by the Baltimore City Department of Social Services with Paths for Families, which is formerly known as Adoptions Together, in September of 2023. Question 5, asking us to comment on specific planned uses for the $28.3 million budgeted to support the rate reform program. The $28.3 million investment supports the new placement provider rate structure to align rates with actual costs for care, provide flexibility for specialized services, and leverage federal funding. The $28 million will support rate reform for 62 residential child care or group homes. The new rate model moves RCC rates to a class-based model and will build on real cost data from the Department of Labor and provider experiences. The referenced $12 million is designed for interagency rate committee rate increases that occurred in FY24 for all contracted providers with the IRC rates. This allocation is to maintain these additional costs for FY25. This is not part of the fiscal note for rate reform. However, the new rate model cost was calculated based on the FY24 IRC rates. Question number 6, with regard to DLS's recommendation to delete $7 million in deficiency appropriation. The department respectfully disagrees with this recommendation. We have worked over the last year with our state agency and provider partners to fill critical gaps in Maryland's continuum of care for youth with complex physical and psychological needs. The rate structure and its success relies on the total amount of funds in the governor's budget. Any cut will negatively affect our ability to implement the reform, jeopardize the model we are building to be responsive to children's needs, as well as place the state at additional legal risk when appropriate placements are not available. Of note, the state of Maryland is the only state in the country currently litigating 3 separate class action lawsuits in child welfare. To question 7, asking us to comment on the reasons for the increase in and efforts that it is taking to reduce the rate of reentry into foster care. There's been a consistent decline in the rate of reentry into foster care for children who unify with their parents. However, more must be done to offer post-reunification services to support families and prevent reentry into foster care. Through our Family First Preventive Care Services Act foster care prevention efforts, we will expand the continuum of care by increasing the availability of supportive services for unifying families. To question 8, asking us to comment on the status of the approval of the revised cost allocation plan and the ability to seek federal reimbursement. The Department of Human Services amended its public assistance cost allocation plan to add Title IV prevention services caseworker activities to the social services time study and to add 4E preventive services cost centers. These updates to the cost allocation plan have not yet received final federal approval. However, DHS has submitted claims based on the proposed plan amendments, which is permitted, and these claims have been paid. The federal department, I will add, is not in the comment, but I will add the federal agency HHS that approves our cost allocation plan is about 2 years behind in approving our amended caps, but they are allowing us to operate as if those have been approved until we hear otherwise. To question 9, asking us to comment on planned future efforts by the QRTP designation work group. We anticipate that in FY25, there will be 8 providers with the designation of QRTP. The additional providers will submit applications with the FY25 budget request due February 15th. That was yesterday. There are an additional 7 providers receiving individualized technical assistance to meet the QRTP criteria. Providers may apply for a QRTP designation at any time. DHS is currently unable to claim 4E funding for non-family-based placements in child care institutions, including QRTP-based placements, because of required federal 4E claiming processes that have not yet been instituted. DHS is establishing within the department the appropriate processes to claim for non-family-based placements, including independent living, mother, baby, and placement serving victims of human trafficking. To the last question, 10, asking us to DLS's recommendation for budget language withholding funding until an updated report is submitted. We are pleased to submit this report. However, we respectfully disagree with the withholding of funds as it will delay the implementation of rate reform. Yes.
I just thank you very much. Acting Chief Financial Officer, to the last issues of proposed language that has been suggested. As you have seen in your packets, there's a combination of those with which we completely agree and those with which we respectfully disagree, and those are in your packets. So at this moment in time, we'd be happy to answer any of your questions.
Senator Jennings.
Quick one. Up in Harford County, we have the Harford Klein Family Center. It takes mental health outside the hospital in a standalone facility. I was just curious if you guys have had any interactions with it with regards to hospital stays with kids and how it's doing. It's the Klein Family Crisis Center is what it's called.
The Klein Family Crisis Center?
Yes.
I'm not personally familiar with that, and I'm
Okay.
looking to my left
No
and right.
problem.
We've
We've been working very hard with getting them money,
sure.
and they've taken, a lot of these patients that normally would go to an emergency room,
Mhm.
gets them out of the emergency room because it's mental health and gets them into a standalone facility.
Mhm.
And I just didn't know, because I know we've had some youth go there.
We're happy to follow up.
Yeah, no.
Only because I don't have all 62 providers memorized.
No, it's
But,
fine.
but
I'm
no.
not trying to
But
put you
we're
on-
happy to
Right here.
because we are constantly looking for new partners. As we meet folks across the state, one of the things we're encouraging people to do is that as part of talking about and actually acting on a new era of child welfare, we have to look at all providers as potentials for those that'll look at becoming a qualified residential treatment program. I don't know that particular program in general, but if they're interested, we are happy to talk with them.
Okay, thanks.
Senator Hadelman.
Thank you very much, Mr. Chairman, and thank you for being here. Great to see my former colleague. I guess I have a question about some of the, and we may hear about this later from what some of the advocates are going to raise. One comment I just want to make is, yes, it would have been awfully nice to have $10 million more to have you provide the services that so many at-risk families and children need desperately. One of the issues, one of the bills that we passed last year, I guess, was Senate Bill 255, and that was directed to the Department of Health. So help me understand kind of where your responsibility and the Department of Health's responsibility lies with regarding providing services to families in their homes. And you have talked a lot about kinship care, and that is the way that is certainly evidence-based to be better for children, and I'm sure less costly for the state. And so if that is the priority going forward, kind of how does that work in providing better, more intensive services to children in their homes of family members?
Sure.
And it just seems to make an enormous amount of sense, and financial sense, and social, emotional, family-centered sense. And given that we did pass this bill last year, kind of where its role is in helping to provide those services, and whether those greatest at need Medicaid eligible folks are getting those services through that legislation.
Thank you for the question, Senator. I'll take a quick stab at it and then also a follow-up with you, because I don't want to speak for my colleague, Secretary Scott, on what they've done. I'll tell you what we are doing together, which is when rebuilding the relationship between two departments that haven't played well in the sandbox historically. And I think the two secretaries and our leadership has been modeling that. I can't tell you how often we are on the phone with each other or in person every single day, even modeling the cross-departmental communication to better understand the data of the same families. So I think we need to start with that, which is we're rebuilding these relationships, number one. Number two, Secretary Scott has been an extraordinary leader in looking at how we can leverage Medicaid dollars more effectively, because we serve the same populations. So that's about sharing back-end Medicaid data, which she's actually had her staff already do. Has already directed her staff, and we've directed ours to better understand what's happening, not just from SSA, but across the continuum of ages. Third issue, which we lifted up in our testimony and also in writing, is around, is really essentially curating how we provide services so we can do more of that in home when safely possible. So for example, you lifted up the piece of the Family First Prevention Services Act. You have to have an evidence-based practice that is used. So finding ways between health and DHS to make sure we can do just what you've lifted up is where we're headed to in this year. We have had a dearth of those services in the last couple of years. So I think that the bill is a step in the right direction. But out of respect for my colleague, I will find out exactly the implementation pieces and distinguish between what they've done specifically and how it ties with ours so that I don't misspeak. Happy to do so.
Thank you.
Sure.
Thank you very much.
Thank you, Mr. Secretary. And usually we have folks come after you to give testimony. So one of the things I usually read all the testimony. Everything is very supportive of your respective agency. I do have one that has some suggestions, some questions that I would like for you to just elaborate or comment on.
Absolutely.
In reference to the hospital overstays, in reference to the respective bids and the work that you're doing. They recognize, or in their testimony, that plays one component. And just to be able to hear what is the agency doing from a community services standpoint would be helpful.
Sure. And I'd love to get a copy of the testimony as well so we can address them or meet them and talk to them. So there's a couple ways we're thinking about this in terms of overstay status. And again, in the spirit of just being really transparent, walking you through some of what we do around this. And one of them is unsticking some of the myths around where kids can go. And so we have to develop more community-based solutions that we currently don't have in place. That's the honest answer, very direct answer to your question. Right now, it oftentimes is an issue of mediating between a hospital itself, a provider that ties right to rate reform and provider network, and community-based intervention services. We need the full continuum of wraparound supports to actually strengthen this work so that you could get more community-based services. And to do that well, we have to leverage a combination of state general funds and federal funds. So I'm just trying to think of, there is a need for more in-home services and family-based care to make sure that that's a more appropriate way to handle the issue. We call it in the child welfare world step-down services, so that if you've been in a more restrictive setting, for example, including a hospital overstay, how do we build more services in Maryland so that community-based providers can provide those supports? They're inconsistent across the state is the very direct answer to your question.
Well, Secretary Lopez, I've always enjoyed your style of leadership because I have very similar. First part of leadership is just acknowledging that there is a problem and then understanding what is the path forward and then giving the appropriate timeline. So just thank you for that first step and look forward to the continuing the conversation and the dialogue around that. As stated, that was the only piece of written testimony of some level of concern. So I'm going to bring up the other witnesses. Sure. I won't give you all your accolades, but I did want to say to Madam Deputy Secretary, so that I don't forget, just congratulations on that 30 years of service to our great state of Maryland. And I just thought about it. I remember dropping something in the door too. I'm going to bring up the folks to give their oral testimony. And the first person that we have is Nicole Green. And if you all can come up as two, so I'm gonna call two names. And Ms. Jane, we'll do 2 minutes is what we'll do in reference to that piece of it. But Nicole Grainer from Community of Behavioral Health Association of Maryland and Robert Bassler from Arrow Child and Family Ministries. 2 minutes.
Good afternoon, Chair McCray and members of the committee. My name is Nicole Grainer, and I'm the Assistant Policy Director for the Community Behavioral Health Association of Maryland. CBH is the leading voice for community-based behavioral health providers serving vulnerable Marylanders. Our 86 member organizations serve the majority of those in the public behavioral health system, providing outpatient, specialty, and residential treatment for mental health and addiction-related disorders. Across the children's continuum, CBH members have clinicians on the ground in over 2/3 of Maryland schools, delivering everything from prevention to specialty services. And they work across the juvenile justice and child welfare continuums of care. CBH members deliver evidence-based interventions, treatment foster, independent living, and residential treatment to youth involved in Maryland's child welfare system. For decades, Maryland's efforts to implement rate reform have stalled, and opportunities to access federal financing have gone untapped. As a result, providers' ability to provide specialty and flexible services have declined, leaving a child welfare system making placement decisions based upon adult needs and available beds, and not the needs of children. It is no secret that the current administration inherited a department with an array of pressing needs and competing priorities. We are grateful that Secretary Lopez and his team have prioritized child welfare rate reform. While rate reform is a priority in this year's budget, we want to emphasize that for change to truly take place, it must remain so in future years. We know implementing rate reform will require both the department and the providers to change practices and operations. We understand that change rarely occurs without challenges, and we welcome the commitment to continued conversation that Secretary Lopez and his team have shared. CBH and the members we represent look forward to opportunities that rate reform supports to improve the delivery of services to Maryland's vulnerable children. We respectfully urge you to support Governor Moore's SSA budget as proposed. Thank you.
Mr. Chairman, other members of the committee, thank you for the opportunity. My name is Robert Bassler. I'm Associate Vice President, Arrow and Child and Family Ministries. Arrow has been serving youth in Maryland for about 25 years. We serve about 500 at-risk youth a year through qualified residential treatment programs, treatment foster care, evidence-based community behavioral health and prevention programs, as well as non-public special education. We are also proud members of the Community Behavioral Health Association and also the Maryland Association of Resources for Families and Youth, where I am currently serving as public policy chair. MARFI members provide residential treatment foster care independent living services to youth throughout the state of Maryland. And I'll start by saying, at Arrow and at MARFI, we fully support the goals of the current administration of Secretary Lopez and his team. All the needs that he spoke about before are pressing needs that have gone unaddressed for far, far too long. Notably, rate reform and also the updating of extremely outdated regulations for the service lines have languished for over a decade. And it is incredibly gratifying to see both of those things moving forward now. As the Secretary's team said, there's a lot of work still to be done. There's a lot of efforts to achieve permanency to help kids not age out of foster care, to develop new programming. It's going to require continued partnership between the department and the provider community, which is why rate reform is so vital at this time. The current rate setting process was developed in the 1990s. It has not been updated since then. Because of that and the way it's structured, rates have in no way been able to keep up with the cost of providing the kind of care that the youth that we're talking about need. And so we really need the rate reform to go through and be funded as possible. So we please urge you to support the governor's budget as proposed. Thank you.
Thank you. Seeing no questions from my colleagues, if we can call up Ms. Sarah Lewis and Ms. Cherish Vick. Seeing no one come at this time, if we can bring up Kevin Keegan from Catholic Charities and Disabilities Rights Maryland. 2 minutes.
Great. Thank you, Senator McCray, Senators. I'm Lucienne Parsley. I am an attorney at Disability Rights Maryland, and we're the Protection and Advocacy Center for Persons with Disabilities. We're the federally mandated, state designated advocacy center, and we represent children with disabilities. And here we are representing children with disabilities who are being kept in overstay conditions in hospitals and emergency rooms, sometimes for weeks and months. We have seen children held for a year or more. And we've been very, very concerned about that. As a result of that, in May of 23, we filed a lawsuit against the Departments of Human Services and Health for failing to provide adequate community placements for these children and violating their rights. We'd been working with them for upwards of 6 years, trying to address this and advocate for remedies to address the problems that we saw. We are concerned that the numbers of kids, while not huge, are higher than are being reported. We've recently found, for example, a 6-year-old being maintained in Washington, D.C. at a pediatric hospital, essentially a pediatric nursing home, who had been fully included in his school and in foster care that had disrupted his medical needs had not changed at all, but because no placement was identified, he was moved to a hospital in DC and has lived there for nearly a year, not receiving any educational services, at a cost of over $1 million a year to the state of Maryland. So we are really concerned that the DHS budget and the activities that they have identified seem very focused on creating new institutional and RTC beds, and sending children out of state, which while RTCs do have a place in Maryland, we believe that the vast majority of kids can be served in the community and actually are being served in the community, even though DHS makes application to sometimes dozens of RTCs for kids. When no placements can be found after a substantial period of time, they are served in the community. Many of them actually do well there. So that's why we really think that the department should be going there first to look to create community services. We really think what's urgently needed is a real focus on prevention and crisis response to prevent kids from going into the hospital. This has been done very effectively in other states.
And Ms. Parsley, if you, we do have your written testimony, so if you can.
I'll
start
wrap
the
it up.
Yes,
Sure,
ma'am.
I'm sorry. We really want to say that, you know, we think that the funding that DHS receives can be used more effectively by concentrating on creating community services. We did want to say that there is a out of overstay report that we believe was due in December that we have not seen yet. The FY22 report was not published till September of 23. So we'd like you to ask the department where that is. And thank you for the opportunity to share our perspectives with you today.
I didn't see that request in your respective letter, so if you can send me an email with that, and I'll make sure to follow up and get it over to you, Mr. Quist. Please.
Senator McCray, members of the committee, thanks for having me today. My name is Kevin Keegan. I'm the Family Services Division Director at Catholic Charities in Baltimore. We're here to very much support the budget allocation for Social Service Administration, and in particular the budget increases to support the provider rates, which again is not just about money, but it's really a new system that's allowing us a greater deal of flexibility. The old IRC process really boxed us in with some of the services we could provide. So this new system will open that up. But you do have my testimony in writing. So given some of your questions, I'm going to just put that aside and just hopefully use your questions as an opportunity. So Senator Hedelman, your question I think was right on point about the overlap between behavioral health and child welfare. And the answer is, moving forward, there really is hardly any. The reason kids are coming into child welfare are primarily driven by their behavioral health or their parents' substance use and behavioral health needs. And the more we can partner with our local behavioral health, the more that is the prevention of kids coming into child welfare. And I think that's what you're hearing from the secretary and his team, which we were very, very much in support of. And Senator Jennings, to your question about the Klein Center in Hartford County, they're very much part of that network with the local department and with our clinic up in Abingdon, as well as the local management board. They're very much engaged. And again, what I get on my soapbox sometimes for, some people that say we're just adult providers. But if you're an adult provider who's treating a parent and that parent has a substance use disorder, they are at high risk of their child becoming in contact with child welfare. So even an adult provider who's treating parents with substance use needs, you are a child welfare provider because you're providing prevention services for kids coming in care. And Senator McCray, to your point, and I hope I don't run out of time on this one, Your accolades to Deputy Secretary Carnitra White during her 8 years that she wasn't downtown, she was the local director at Anne Arundel County. And when she was there, she reached out to us at our Anne Arundel clinic and started the first PCIT program in Maryland with our, in partnership, it's with the local Department of Social Services as well as the local behavioral health clinic. So the leadership of this administration understands that really is where, how we're keeping kids out of care. We now have 3 sites of PCIT as well as Allegheny County and Baltimore County. And one of the notes in the legislative audit report was that 0 kids who have received PCIT services have ended up coming into child welfare services. And I think that's a huge point to highlight, and I appreciate you noting that in your report. I'll stop there. We're very much in support of this budget. Thank you.
Yes, sir. Seeing no questions from my colleagues, to everybody that gave testimony, I just want to say thank you. Thank you for your advocacy. Thank you for what you all do for our young folks that desperately needed, the vulnerable population. Mr. Secretary, I reiterate that I did not hear any excuses. I heard where we fall short as a state. And I feel very confident that we'll move in the direction that we're supposed to be going. And Mr. Quish, just thank you for always making sure the word kept up to date and up to speed. We'll make sure to follow up with the report that you had discussed as soon as you send the email. And just thank you again. Colleagues, saying that this was the only agency hearing, this ends the